Good afternoon. My name is Lawrence Wary. I'm an assistant professor at Sargent College across the street and also spent some time at the School of Public Health in the Department of Global Health. Full disclosure, I am African. I'm born and raised in Kenya. A lot of what I'm going to talk about reflects my interest in health systems and how we can optimize health systems for marginalized populations. With most of the studies that I'm going to share focusing largely on Kenya, but apply to other areas in Africa that I work in, Ghana, South Africa, and similar places. So here at Boston University, I run what I call the Global Health Systems RISE Lab, and the RISE means research on insurance, social determinants of health, and complex humanitarian emergencies. And so we try to figure out how can we use health systems as spaces to respond to social determinants of health, health system reforms, and complex humanitarian emergencies that affect different populations, such as immigrants or informal sector workers. Jonathan talked about M-Pesa, and we've had conversations about potential collaborations because this sits squarely in the informal sector, and also thinking about people living with HIV and mental health challenges, and as well as mothers and their children. So one of the projects that I'm currently leading is, as part of the SDGs, the world is interested in achieving goal number 3, that is about health for all and well-being. And at the core of this is the idea of universal healthcare coverage. How can we provide access to people, especially marginalized populations, in ways that make sure that their rights are respected and that it's affordable to them without any catastrophic expenses. And I believe that for us to be able to achieve universal healthcare coverage, and if we're using this health insurance as a mechanism, we need to understand what are the dynamics around insurance enrollment. And so we're doing this work that we are calling health insurance deserts. And what we're trying to do here is to characterize geospatially and temporally the places in which people have insurance versus where they don't, by accounting for population density, accounting for insurance coverage, accounting for how long does it take to get to insurance enrollment centers, because you have to go to enrollment centers to be able to enroll in health insurance, as well as our healthcare facilities accessible. And so what you see here is the map of Kenya. And you notice the far left there, right around the capital, Nairobi, and the more urban settings, the blue indicates that there's less insurance deserts there. But if you go around the country, the northern frontier and the coastal region, then you're more likely to find more insurance deserts. The second picture is just weighting by travel time to insurance offices, and then weighting by gender. And we see that there's huge disparities, especially for women, when it comes to health insurance enrollment. The second thing that we're interested in is how do we actually deal with informality? And the reason why this is important is because in sub-Saharan Africa, Southeast Asia, a lot of the working population do most of their trades in the informal sector. And being in the informal sector goes against the mechanisms that we're trying to use to achieve UHC. So how can we embrace universal healthcare coverage in a setting where majority of the people that need the coverage are actually in the informal sector? Third, because of my work in the informal sector and HIV, one of the things that became apparent to me back in 2021 when I was doing a household survey around the region in Kenya was the impact of climate on HIV. And the reason why this became interesting was because in fishing communities, HIV is attributed to a transactional fish for sex relationships. And we know that climate change is impacting the lake ecosystem, but we haven't answered the question of what is this doing to HIV risk factors. And what we find that both flooding events and heat wave intensities increase the risk factors for HIV acquisition and prevalence within the lake region. And some modeling studies have indicated that climate change is likely to lead to up to 100 million new HIV cases by 2050, 2060. So the link between climate and HIV is something we're trying to explore. And we're also trying to do the same with mental health by trying to integrate mental health services into HIV care settings. And finally, we're also trying to figure out how can we, where do we place healthcare facilities to be able to address maternal and child health morbidity and mortality? And so thank you for your time.